So please take your seats. Okay, thank you. Let's get started. I'm Elizabeth Fox from USAID. I have the best job here, which is working in health, infectious disease, and nutrition, which includes our MCH program. And I also have the best job this morning, which is two things. Saying thank you to MCHIP. And you've been amazing. How many of you were here yesterday? It wouldn't have happened without MCHIP. It was wonderful. And thank you for everything. The second thing I have to do is a real pleasure, which is to introduce Deputy Assistant Administrator Katie Taylor, who is now in charge of the hidden office and the MCH program in that office, and has been a real champion of everything you saw yesterday. And I think you'll see that her work in this area in ending preventable child and maternal death is going to be very important going forward. So I'm very pleased to present her, and needing no introduction, of course, and coming to us with a wonderful combination of international experience, private sector experience, and work in the faith community. So Katie, please join us. Thank you.
Good morning, everyone. Bonjour. Ahlan wa sahlan. Bon dia. Bienvenue. Karibu sana. And I wish I spoke all the other languages. Oh, maybe for DRC, Mbote, Sangunini. I will be brief this morning. There are two things I would like to talk about. One is to say a few more words in thanks to MCHIP, which I will do in a moment. And the second, to welcome and acknowledge amidst us the presence of our wonderful, wonderful ministerial delegations from our 24 priority countries, so, which I will also do in a minute. But first of all, I'd like to expound on what Elizabeth said. We would not have been successful yesterday. We would not have been able to put this report out if it hadn't been for the extraordinary work of everyone in MCHIP. And we thank you. We thank you deeply. Thank you. I know you worked nights, I know you worked weekends, I know you went above and beyond the call of duty, and I just don't have words enough to express our thanks and our gratitude for you being such fine and just wonderful, wonderful partners. So you know who you are, and it's just a privilege to work with you. Now, that brings me to my second theme, which is to once again welcome our ministerial brothers and sisters, if I may. Your Excellencies, it is a delight to have you here. Much of the conversation yesterday and this morning was around how we can be better technical and financial partners. And so the idea of having you be here with MCHIP and our follow-on, the Maternal and Child Survival Program, is to ensure that we create the very open working space that to continue the conversation that we have had in your countries with our missions, but also the conversation that we've had yesterday and today. And so in order to do a little bit of that, I thought it might be useful to share with all our with everyone here who wasn't able to attend the breakfast we just had with our assistant administrators and other colleagues from the agency and Dr. Shah, would be to share with everyone what are some of the themes that emerged from that. Would that be helpful? I'm being a little bit impromptu. So, and again, Ministers, Excellencies, if you'd like to continue these conversations and questions today, this is a good forum to continue with the questions you already began to express this morning. So essentially, we heard four big themes in this morning's interactive conversation. The first I would like to mention would be leadership. The importance stated by the ministers themselves of their national leadership, their government leadership, and the individual leadership that they represent, and ensuring that there is alignment between us and the direction that they are that they are leading their countries in. We acknowledged openly that there is sometimes a tension between national plans that may focus on health system strengthening, platforms, management, human resources for health, quality, and funding that may still be, that is still disease specific, and resources that need to be measured and accounted for against the desire to achieve certain disease-related objectives. So we acknowledge very openly that there is sometimes a duality, but that we are intending to support the national plans with all of our efforts, because that is where the leadership is. So ensuring that alignment. A second big theme was funding. There were a number of questions around, well, how does USAID funding really work? Which we know is a complicated, so there were questions about allocation across countries, about pooling, about how awards work, what the significance of the $500 million award, new Maternal Child Survival Program award represents. Was it new money or not new money? So there were all sorts of questions around that, which we answered to the best of our ability. But Excellencies, if you have more questions, we're happy to continue that. There were also a number of questions around government funding specific to things like, can we support them in doing more pooled procurement across countries? Can we support, or at least ask our Congress to be more supportive of pooled funds or commingling of funds? And can we find ways of trying to enhance predictability of funding, not just USAID and US government funding, but support and trying to find additional funding streams? And we're already trying to do a lot of that in aligning with other donors and partners and looking at innovative financing mechanisms. I was just having a side conversation with Minister from DRC, Dr. Felix Kabange, precisely about some innovative financing and securitization ideas he has in mind. So second theme was funding. The third theme was around process. There was wonderful, we thanked our participants and delegations profusely for the honor of joining us in this meeting. There was a desire to not just continue the conversation on an ongoing basis, but maybe meet yearly, and our administrator committed to that. So perhaps a yearly meeting of this kind where we work together to take the sorts of frameworks that we began to outline in this report and then expand on them and look at how have we delivered a year from now? How are we aligning with them, and how do we move forward? So on the process side, there was from a number of countries, in particular Nigeria and Pakistan, but others as well, on national plans are vital. They help us align, but it is also fundamental to look at the subnational level. To do better, and they're asking for our support, USAID and our implementing partners, to do better at ensuring there's communication and collaboration, particularly in federal systems, between the national level and the subnational level, be it states or regions or further down. So that's theme 3 on the process. And the 4th theme was evidence and measurement. So we talked a lot about different aspects of that, about the importance of scorecards and dashboards to ensure that we have a simple way of making sure we're aligned and supporting the ministries at national level and then all our partners in country of making sure we're all, as much as possible, looking at the same data. So those are the 4 big themes: the leadership and alignment, the funding, the process, the evidence, and the measurement, 4 key themes. A pending question that came up in a number of times, but we didn't have the opportunity to address, but we would like to do going forward, is the importance of the private sector and supporting ministries in developing private sector solutions, be it engagement of private sector in clinical services, be it engagement of the private sector on financing schemes, be it engagement of the private sector in distribution. There are many, many different ways of engaging the private sector, as there are also many different ways of engaging civil society and faith communities, as we discussed in one of our panels yesterday. I'm waving to Bishop Sunday from Nigeria. So I just wanted to share with you a little bit of the conversation we had this morning so we can all continue that conversation during the course of the day. And then I believe it is now my pleasure and privilege to introduce Nahed Mata, who is the real star of today from the USAID side.
Thank you so much, Katie. And really, your words was a great start for the day, and we were all anxious to know what happened during the spec. So thank you very much. Excellencies, distinguished guests, colleagues, and friends, good morning. And I'm not as talented as Katie, so I will only say good morning and maybe sabah al-khair and bonjour. That's it. A big welcome to all of you. It's a great pleasure to have you all today to attend this technical close-up event for the USAID's flagship project, Maternal and Child Health Integrated Program, otherwise known as MCHIP. I am Nahed Mata, and I am a Senior Maternal Newborn Advisor at the MCH Division of the Global Health Bureau. And in your agenda, I am called the AOR. So as an AID manager, I really want to note that I am supported by a great team of colleagues from USAID. All of them are here, and we're only missing a key partner, Malia Boggs, who just had a baby, and that's why she couldn't make it. But she and the baby are doing very well. We are all very fortunate to work closely with MCHIP almost on a daily basis. We are delighted that this day was selected for the MCHIP close-up event after the acting on the call Ending Preventable Child and Maternal Death Forum. This allowed our esteemed ministers, country delegations, and all of you to join us today and makes this day very special. We could not have planned for this day any way better. Yesterday, we celebrated the progress made in many countries to end preventable child and maternal death since the 2012 launch of Committing to Child Survival, their promising youth. We heard about great country experiences and serious commitment from our government, from the country governments to achieve further progress in the field of maternal and child health. The Yemen team had the chance yesterday to discuss with His Excellency the Minister of Health, Dr. Ahmad Al-Ansi, the recent result of the Yemen GHS, released only a few days ago. He had a hard copy with him, and he was very anxious to share the results. It is showing impressive declines in both maternal and child mortality, almost around 50% between 2013 and 2003. Also, the fertility rate reduced from 6.2 to 4.4. Progress such as this, happening in a country like Yemen during a period of political unrest and economic difficulty, is very inspiring and provides great hope that even more could be achieved to improve services and end preventable child and maternal death. This is exactly what the minister has told us as he returns back with great enthusiasm to sustain these gains, inspired by all the opportunities and the learning experiences from these 2 days. We are pleased that the mission in Yemen has an agreement with MCHIP for another 4 years via what's known as an associate award, and thus USAID through MCHIP will be able to assist the ministry with its goals in the future. I know that similar great results from the DHS has been shared recently from many countries. Just as an example, Bangladesh, Rwanda, and DRC are really doing well. Distinguished representatives from various countries, I must say that good news about the progress made in your countries after the release of the DHS is being circulated widely at AID. We rejoice and celebrate. We talk about these results over the corridors, as well, of course, as organizing a meeting to discuss. We also feel great and proud that USAID contributed to the government efforts. In fact, 1% decline in child mortality rate means 1,000 precious lives saved. So please keep sending to us those great news, and we thank you very much for your work to make that happen. Today, we are celebrating the end of the MCHIP project, but also the beginning of USAID's new flagship project, the Maternal and Child Survivor Program. With a clear vision of acting to end preventable death, we are pleased that the new project will build on the experience and success of MCHIP's work in many countries and strong partnership developed with you all, the Ministers of Health, the local counterparts and partners. We are energized and inspired by the acting on the call deliberation and believe that this is an opportune time for our new project to build on this great momentum and apply lessons learned for future efforts. Both the MCHIP and the Maternal and Child Survivor Program were designed to address a wide range of technical areas covering the continuum of care from pre-pregnancy to age of 5. It includes activities covering maternal health, child health, newborn, immunization, nutrition, family planning, malaria, and HIV/AIDS. My colleagues at AID, led actually by Elizabeth, were happy to see that this integrated design is working. We previously had 6 different vertical programs. And actually, it has been designed to satisfy the needs of many countries by providing support to a wide range of technical areas as one-stop shop to save the lives of children and women around the world. The number of countries buying into MCHIP reached around 40, in addition to those requesting technical assistance from the global funds, bringing the total number of countries to 50, and that is really a proof and testament to that desire from the countries to buy into such an integrated program. All MCHIP partners, led by JAPIGO, had extensive experience in all these technical areas and have worked in many countries to advance maternal and child health services supported by USAID for almost 3 decades. We are thus proud and happy to continue working with this great partnership. The new USAID flagship project, announced just yesterday by Dr. Ayer Pablos Mendes, will build on MCHIP experience and lesson learned. But the team for the new award, which has most of the same partners, knows that the expectation is high. We learned that MCHIP should explore opportunities for better integration. We want the new project to take on and scale up new proven innovations. We want to work harder to support the health system to address basic cross-cutting themes such as gender, WASH, equity, health, community engagement, and behavior change communication. All are priorities to the maternal child program, and some of that actually has been implemented through MCHIP, but we want more. We have done great, but we want to do better under the new project. This new flagship project will stand ready to assist countries with their specific technical needs in order to fill the gaps in implementation or a specific area or be a comprehensive program for them. The Maternal and Child Survivor Program is also expected to be one of the key flagship programs to support AID's goal in ending preventable child and maternal death. We know that the project can deliver because of the dedication and commitment of its leadership, Dr. Koki and her team, and the highly skilled technical expertise of the various teams and the strong consortium you are. As far as today's MCHIP close-up agenda, it was designed to cover selected themes, and we hope will be of great interest for all of you. The topics to be discussed represent a snapshot of MCHIP work and by no means covers all what has been achieved or implemented. The three selected themes are quality, community, and scale up. The MCHIP teams worked hard to synthesize the experiences and develop the presentations and panel discussions that we believe will be of interest to you. We are happy to have with us the MCHIP country teams who are leading the work at the country with their associated MOH partners. They will present the program efforts, share the achievements, in addition to challenges and recommendations moving forward. We are pleased also that the program will include a very exciting luncheon panel with esteemed ministers of health, allowing them the opportunity to share their country experiences in advancing maternal and child health. I hope you will enjoy the presentation and discussion and stay fully engaged. In conclusion, I want to say on behalf of my USAID colleagues working with me on the MCHIP and the Maternal and Child Survivor Program that we are delighted and privileged to continue working with this exceptional team to achieve our mutual goals of ending preventable child and maternal death. Thank you very much, and I hope you will enjoy the day.
Good morning, everyone. I'm Koki Agarwal. I'm the director for the MCHIP program, and it's my task today to share with you what MCHIP has done in 6 years. So I feel like, we talked about celebrating the 5th birthday. This team has nurtured MCHIP to celebrate not only the 5th, but also the 6th birthday. So I'm excited to share with you some of the learning that has come from MCHIP. And as Nahed said, by no means can we actually share everything that has been done under the MCHIP program on this day. But I really hope I can share with you some key lessons that we have learned, just give you an overview of what MCHIP has been able to accomplish. So starting with what we have done in these 6 years, we have had as a global project the ability to have a seat at the table where we've been able to engage with the different UN agencies, different forums to bring the policy bearings to country level. And we have also had our feet anchored at the country level so that we can share the lessons from the countries and bring that evidence to the global agenda. So I think that shared learning from the country as well as from the global to the country level has been an amazing part of our journey. We have also learned and had an impact on the scale-up processes. We were challenged by our USAID colleagues to say, okay, what do we mean by achieving impact at scale? We have spent a lot of time thinking about how countries can achieve scale-up, and you'll see that this is a big part of what we are going to be able to share with you today. And we have also been able to work and take the best from the partnership that came together to implement MCHIP, bringing together excellent technical skills. And we've been able to garner those skills to really achieve what we want at the country level to support our country programs in whichever way possible based on the context in which we were working. So just to familiarize you with what the goals of the MCHIP program at the outset were, we were to contribute to reductions in maternal and under 5 mortality, achieving impact at scale, making sure that we brought global leadership and learning to the forefront, and support USAID NGO grantee programs. We have done this in many countries by working in the 26 countries which have the Child Survival Grants Program, supporting 37 projects, and also making sure that we are supporting their OR operations research in 22 countries. So what the MCHIP priorities that were outlined and emerged as we went along our incredible journey was to take high-impact interventions to scale, create change through global and regional learning and influence. So we have worked on multiple policies, program guidelines with international partners, and then brought that learning to the country level. We have also ensured country ownership. One of the things that came out as a result of our midterm evaluation was that they found that we worked very closely with the countries based on the context and then decided how we can work together to enhance the support that that country needs. And we have tried to engage in many issues relating to measurement and evaluation and use of data at the global and the country level. Many of our teams have contributed in their technical areas to make sure that we are looking at what measurement issues need still to be addressed, whether it's at the global level, designing the indicators, or helping at the country level, making sure that they are included in the health information systems that countries are collecting. We have also had the opportunity, because of the design of our program, and thank you USAID for designing this program the way it was, because we have had the opportunity to have different technical teams work together and expand opportunities for integration across the different technical areas. So as Nahed mentioned, this program was implemented with JPIGO as the prime, but with working in partnership with many technical partners like JSI, Save the Children, ICF, PATH, PSI, Broad Branch, and Institute of International Programs from Johns Hopkins University. Together, we have been able to work at many, many different countries and many different global and regional forums. So when we started in 2008, there were many existing USAID projects that were still working to support countries in maternal newborn health, child health, immunization. And then as we came together, you can see that in year 1, we had very few countries that we were working with. But going forward in year 2, we added more countries which we were supporting. Year 3, our program still grew to add more countries, and working in most of the countries where the need was the greatest. Year 4, we added more countries, and then year 5, we were still adding more countries. So as a result, we are still in the process of closing out this program, because we had some amazing programs that we had opportunities to learn from and have research results that we want to share with the global community and at the country level. We also, as Nahed mentioned, she actually shared results from some of the associate awards. We have country programs that are continuing beyond the life of MCHIP through these associate awards. In Bangladesh, we have had 2. One is ending, and one is ended, and the other one is started. Mozambique, South Sudan, Pakistan, we have 2, Malawi for voluntary male circumcision, Zimbabwe, and Yemen. And through these country programs, we've been able to offer a comprehensive approach to maternal, newborn, and child health with a long-term vision of how we can support these countries. At the global level, USAID has designed many global development alliances, and MCHIP has had the privilege and opportunity to support and work with all of the global development alliances that were designed under USAID leadership. So these were mobile action for maternal action, hand washing for newborn health, helping babies breathe, empower, and survive and thrive. And some of these are still continuing under MCHIP, as well as will continue under the new award. So because of the design of the project, our work really begins at the household level. We work with the country programs to see where, in what appropriate context can we make sure that women receive services at the household level where they may not be, if they're not able to come out to the facility. We also support the communities to become more empowered. This can be through community engagement. This can be through women's groups. This can also be through micro-planning meetings that we have with governments and the community groups. Another aspect of the work that we have done is to ensure that there's effective referral between the household hospital and the hospital. And then, of course, a big part of the work that we have done is to support facilities, clinics, hospitals, maternity waiting homes to become better equipped to be able to serve the clients that are coming in. And this has all been in conjunction in supporting the ministry programs, supporting the NGO programs, whatever has been in existence at the country level. The other aspect of the continuum that we support is looking at the issues that are required to address from pre-pregnancy to under 5. I think this is the first time under USAID leadership that we were able to address comprehensively the whole continuum from pre-pregnancy to under 5. And we have been able to also look for opportunities where we can integrate interventions that will help. For example, in family planning and immunization, we tried to look at how during immunization visits more family planning messages and services can be delivered. And we see good results coming out that we can share and work with the larger community. I also want to share just the results in terms of the numbers that have been achieved. So we'll move forward with a short video. So moving on, just to recap, in many of what you saw in the video, we were working in postpartum hemorrhage prevention in 30 countries to expand, looking at addressing the comprehensively how you prevent postpartum hemorrhage and manage it. Newborn resuscitation in 25 countries through taking the initiative of helping babies breathe, and kangaroo mother care in 24 countries, essential newborn care and postnatal care in 13, addressing preeclampsia, eclampsia, which is still a major cause of death for women, in 15 countries, making sure that we can address postpartum family planning, which was an opportunity awarded to us through this integrated program in almost 13 countries, looking at child health, integrated case management in 9 countries, looking at underutilized vaccines, new and underutilized vaccines in 11, and through the PMI countries, which I believe are 19, we worked in 7 countries to address malaria and pregnancy. The other aspect I wanted to highlight is the global leadership. As a global project, we have worked not only at the country level, working hand in hand with the government to see how we can support their programs and enhance and strengthen their health systems. but also had the opportunity to work with multiple partners at the global level to contribute to committees or program guidelines or being at the seat with decision making when it comes to developing national, international, and national guidelines. And this has been able, we have been able to translate that into our program learning. You can see that we contributed to 179 national policies and guidelines at the global and country level. And as a research, we are not a research project, but as a project that has been able to bring and hone in the learning from our country work as well as our global leadership, we have 60 peer-reviewed publications. And this, again, was something that, as we were discussing our learning with USAID, they said, well, tell us what you're going to bring together in terms of learning. And we are really proud to say that we have 60 peer-reviewed publications at the end of this program. We also, just to remind you that in your folders as you came in, the nice picture that you see, which looks like a business card, is actually the flash drive that has all the learning from the different technical areas that we have worked in. So please make sure that you see that in your folders and not throw it away. We have also had an opportunity to bring together and convene global partners, national level, country level, individual stakeholders from civil society, professional associations in 4 large regional meetings. These meetings have brought together these wonderful people to take an opportunity to have shared learning and talk about what needs to happen at the country level. In these meetings that were convened in Addis, and Dhaka, Johannesburg, and Accra on different themes. Addis and Dhaka were on maternal newborn health. Johannesburg was the first global newborn meeting, and Accra was on ICCM. We brought together individuals from 30 to 50 countries working with other partners like UNICEF and many other partners who are in this room today, and had an opportunity to discuss shared learning, what needed to be done. And we don't really feel like we don't stop at meetings, and we want to make sure that we can understand what happens after a meeting is happening. And we, as a result of these meetings, we have been following up that we saw that 7 countries expanded their PPH programs. What they learned, what they saw at this meeting, they felt they could do more, and we were able to support and work with these countries to expand their PPH programs. Several countries came together to give global commitments to the Every Newborn Action Plan that was launched and will be launched at the PMNCH meeting coming up in Johannesburg in a few days. And there was a multi-agency commitment to support the ICCM Evidence Symposium. So we have been able to bring together and then leave with a commitment to carry on that work beyond the meeting. For one of the quotes that I wanted to share was that this is from a USAID Ghana respondent who said, "My country team is developing a post-conference plan that will include general information and on lessons learned on the newborn and recommendations on what we can adopt at the country level. This plan will be shared with the host country health leadership for adaptation. At the focal point for the agency, I will follow up with the ministry." Also from the Dhaka meeting, which was on maternal newborn health, one of the Pakistani delegation members said that we have changed, as a result of the meeting, they went back and changed the language and the guidance on misoprostol distribution for preventing postpartum hemorrhage at home births. He said, "We have changed, misoprostol was not part of the essential drug list, and due to the group following the conference that has been incorporated in the provincial essential drug list." And you can see below the newspaper article that talks about that. But it's not all about numbers. Eventually, what we want to do is to touch lives of people, improve their lives, and make sure that they have a healthy, happy, safe delivery and a happy childhood. Our work has led us, so I can't share with you stories from every country that we have worked in, but I chose a few to share with you today. So this is a story from Zambia, where we have worked under the USAID-funded Saving Mothers Giving Life program. This is a story of a clinical officer, Kakungu, who examines a pregnant woman who's in labor and discovers that the baby's hand is malpositioned. It is a potential complication, he knows. In the past, he freely admits he would not have known what to do, and he would have referred the woman to a very faraway facility where he would not know whether she would make it there or not. But after having participated in MCHIP training on emergency obstetric and newborn care and clinical mentorship that he received from the program through Saving Mothers, Giving Life, he helps shift the position of the baby's hand and assists the woman in a safe delivery, and the baby is delivered healthy. Another story from Pakistan, where Abida, a 36-year-old woman, arrives at a hospital in Pakistan after prolonged labor at home. She is exhausted and her baby is in distress. The mother, with the last push, delivers a baby girl. But the newborn isn't breathing. Nurse Tasleem moves swiftly, pulling into practice every resuscitation skill she has learned through the MCHIP's Helping Babies Breathe training. She lifts the baby from the mother's chest, uses a sucker bulb to clear the child's airway, cuts the umbilical cord, and places the baby on a table where she uses an ambu bag to resuscitate. And within that golden minute, the baby begins to breathe and her skin pinks up. I was so proud when I gave this crying baby to her mother for her skin-to-skin care, said Nurse Tasleem. In Liberia, Martine, a Liberian mother pregnant with her fourth child, always gave birth at home, but a traditional midwife that our program had trained worked with her to say that you should deliver at a facility. The health facility was 3 hours away, but she had given her the knowledge to go to an antenatal care visit and be trained about the 3 pills she can take if there is to prevent postpartum hemorrhage. So when Marthalin's labor began, there was no transport available, unfortunately. The family called the traditional midwife who helped deliver the baby and then gave Marthalin the 3 pills that saved her life to prevent postpartum hemorrhage. Liberia is one of the 15 countries where MCHIP has supported expanding postpartum hemorrhage to work to deliver something at the household level when women cannot make it at the facility. Another story from Uganda, where Alex, a nurse in charge of a district in Kabele district, he thanked the MCHIP staff for training him so that he can now identify the catchment population and target the most needy for immunization services. We now know which villages to focus on and which populations to target. We can track and access utilization of immunization in these populations. So what would I like you to remember about what MCHIP has been? It has been a program that has allowed us to work at the global level and have a seat at the table and make sure that our feet are anchored strongly and firmly in the ground, working side by side with government programs, NGOs, faith-based groups, private sector, facilities, every stakeholder that we can think of at the country level. We have really taken a lot of effort to learn what is it about achieving impact at scale, and you'll see that this is discussed in the afternoon sessions, because we invested in trying to find out how do countries scale up, how can they improve that scale-up process, what have we learned, and how can we provide some technical assistance when countries are facing bottlenecks and barriers to scaling up certain interventions. And then the third aspect is just the partnership that we had together to bring in the best of the technical expertise of this partnership to optimize and to highlight what the program can really do synergistically across all the technical areas that we were trying to support and work in. So as I said earlier, that we had 5 years of MCHIP. I think that's good birth spacing. And we have to move forward, as I had said, towards a new program. And we have learned a lot in this 5 years that we have nurtured MCHIP that we will bring to bear and take forward in this new program. And we look forward to having all your support, because I know the expectations are high from not only USAID, but our government counterparts. And eventually we want to really meet the expectation of that woman who's in a rural area with her child, who does not have access to a facility, but is trying to make her child survive and herself have a healthy, safe pregnancy. Thank you.
I would just like to invite Debbie Armbruster and the rest of the panel for quality first, which we'll be hearing about next.
morning to all. To all our distinguished guests, the excellencies, and the ministers who are here today. My name is Debbie Armbruster. I'm a person who works closely with NAHED. I'm also a senior maternal newborn health advisor at USAID. And I've had the privilege to work with MCHIP over most of its life, but not all of its life, and to appreciate the incredible expertise and hard work that MCHIP does to try to, in fact, save mothers and babies and children around the world. Today, we're going to talk about quality and the work that MCHIP has done in quality. And we have a distinguished panel here of MCHIP staff. We're going to start with Barbara Rollins. She is the MCHIP Monitoring and Evaluation Leader, and she's going to provide a quality overview. She serves as the M&E team leader for the MCHIP project and holds the designation of an associate professor in the Department of International Health at Johns Hopkins School of Public Health. She's been working in public health and M&E for over 20 years and in international development, and has focused on maternal, newborn, family planning, and reproductive health programs. She's worked around the world, has lots of experience, and as a former Peace Corps volunteer, I will say she's also a Peace Corps volunteer. Barbara's done great work, and she's going to start us off.
Thank you, Debbie. I'd like to provide a brief overview of MCHIP's work in terms of approaches and contributions to improving and measuring quality of care. I think we would all agree that quality of care is important. And the situation that we see here in this photo is not acceptable. This is a photo from a health facility in one of the countries where MCHIP is supporting quality improvement approaches. And the unsanitary conditions that you see here do not motivate women to deliver at facilities or provide them with a satisfactory experience or a safe experience in which to deliver their baby. There's also recent global evidence that points to persistent and widespread gaps in quality of care. For example, several sub-Saharan African countries have shown increased rates of antenatal care and safe birth attendance, but we have not seen corresponding decreases in maternal mortality. There's also been a recent WHO multi-center study published by Souza et al. That showed that although there was no correlation between maternal mortality and implementation of any known life-saving interventions, such as provision of magnesium sulfate for preventing preeclampsia, eclampsia. Following the publication of WHO's Global Strategy for Women's and Children's Health, there have been a number of global initiatives that have emerged that have underscored the importance of improving and measuring quality of care, including Every Woman, Every Child, the Commission on Information and Accountability, and just yesterday, USAID shared more with us about their plans for ending preventable child and maternal deaths and underscored the importance of ensuring quality of care. So I think we would agree there's global consensus that only through delivering services of sufficient quality can health impact be achieved. But what is quality? One of the first systematic frameworks for describing quality was developed by John Abedian in 1966. And he organized quality into three categories: structures of care, processes of care, and outcomes. Structures of care really refer to the health facilities, the staff, supplies and equipment. Processes of care refer to client-provider interactions. And outcomes refer to the effects of health services on clients in terms of morbidity and mortality. More recently, WHO has identified 6 domains to describe quality of care. Those include effectiveness, safety, acceptability, and patient-centeredness, accessibility, efficiency, and equitability. And the panelists in our session here will be talking primarily about the first 3 domains, but MCHIP has addressed all 6 domains in its work across multiple countries. So MCHIP has supported several different approaches to measuring and improving quality of care, and I'll just provide a few highlights now of some of the work that we've done. But first of all, MCHIP has contributed to improving the measurement of quality of care. MCHIP developed a health facility survey to assess the quality of antenatal and labor and delivery care that was implemented in 7 countries in sub-Saharan Africa. And the main objective of these assessments was to determine the frequency and quality with which evidence-based interventions were providing during antenatal and labor and delivery care. And a notable feature of this survey was the fact that it actually included direct observation of labor and delivery care, which is unusual with large-scale health facilities surveys, which tend to focus more on facility readiness. In the picture here, the picture to the right, you can see one of our data collectors actually observing a birth and recording the information on a mobile smartphone. And one of our panelists will provide more information about the results of these surveys, as well as how the results were used in the 7 different countries. A major priority for MCHIP also has been working to improve the quality of health services. There are several different approaches for improving the quality of healthcare on a continuous basis that have been implemented in low-resource countries. And these have been documented in a report called Finding Common Ground. But common to these different approaches is a systematic series of steps to improve quality that can be represented by the Plan, Do, Study, Act cycle. And this cycle, which is sometimes called the Deming cycle, starts with the plan step, where objectives and action plans are developed and identified. The next step, or the do step, the action plan is implemented. In the study step, progress is measured. And then in the act step, the learning is gathered together and used to inform and revise the plan if needed. And then these 4 steps are repeated in a continuous cycle of improving quality of care. MCHIP has supported 2 primary quality improvement approaches. One is the standards-based management and recognition approach, which MCHIP and partners have applied in 17 different countries across Asia, Africa, and Latin America, and across the full spectrum of reproductive, maternal, newborn, and child health services. And this approach is a little bit different, sets itself apart by the fact that it includes a recognition piece whereby facility-based teams that achieve desired quality improvement results are recognized by their peers and colleagues. And one of our panelists will be telling you a bit more about the experience of applying this approach in Zimbabwe, both the process and the results achieved. Another approach that MCHIP has applied extensively in India is the regular appraisal of program implementation in a district, or RAPID. And this has been applied to improve immunization services at the district level and integrated into supportive supervision processes. And one of our panelists will also be telling you a bit more about the process of doing that and the results achieved. MCHIP has also supported important approaches to patient-centered care, in particular respectful maternity care. And respectful maternity care consists of supporting patients' rights and preferences in terms of their birth experience, including their birth position and their preference regarding having a birth companion present at the delivery. And in the illustration in the upper right, you can see this woman is delivering in a squatting position, and this illustration is from a manual on respectful maternity care that MCHIP developed that is currently available on the Cave for Health website, and includes resources and tools about how to integrate respectful maternity care into quality improvement efforts, and also how to measure respectful maternity care. In addition, MCHIP has supported community-inclusive approaches to quality improvement, including partnership-defined quality in Mozambique and client-oriented provider-efficient services in Nepal and in Kenya. And the recent MCHIP Associate Award in Mozambique has included partnership-defined quality as part of its efforts in a select number of smaller health facilities to engage communities and better link them to health facilities, and also make sure that communities' understanding of quality is part of their definition of quality. The Child Survival Health Grants Program has also played an important role in supporting community-inclusive approaches to quality improvement. And MCHIP has provided technical assistance to those grantees. For example, this photo here shows TBAs in Kenyan communities in Busia that have been involved in applying PDQ with the support of AMREF, a child survival grantee. Also, the Adventist Development and Relief Agency, another CSHDP grantee, has worked to implement COPE, client-oriented provider-efficient services, to improve family planning services in Nepal. And this is a participatory activity to help facility staff realize the importance of using self-assessment and client exit interviews. And they found that client satisfaction improved in health facilities implementing this approach. So in conclusion, as we look ahead, as countries strive to meet their goals moving beyond the MDG agenda, we see that continued investments are going to be needed to scale up quality improvement approaches and also to ensure that measurement and learning is supported. And then that learning in turn is fed back into decision making to guide quality improvement efforts at the country level, health facility level, and community level. Thank you.
Next, we're going to have one of the senior staff on MCHIP and a wonderful midwife who does excellent work, Sheena Curry. She's the MCHIP Senior Maternal Health Advisor, and Sheena provides technical and program support in maternal health for MCHIP. She's a British-trained educator and midwifery educator and a maternal and newborn expert who's worked extensively in low-resource settings. She spent a lot of time in a number of countries around the world, providing technical guidance in development, management, and evaluation of maternal and child health newborn programs. She's going to speak to the quality of care assessments that Barbara was speaking about. Sheena.
Thank you, Debbie, and good morning, ladies and gentlemen, friends and colleagues. Barbara has set the context for the quality work that MCHIP has carried out, and yesterday, for those of you who were here, I think quality was mentioned in every presentation. So it's a very, very important theme for MCHIP. And I would like to share with you the findings of quality of care assessments that were taken in 6 African countries. The objectives of the quality of care studies were to assess the prevention and management of the most serious maternal and newborn complications during pregnancy, labor, and delivery. And we focused on postpartum hemorrhage and preeclampsia, the 2 main causes of maternal death, and newborn asphyxia, one of the 3 main causes of newborn deaths. The methods focused on the processes of care through direct observation of client-provider interactions. We also conducted provider interviews and audited the supplies and equipment available in the facilities. Direct observation of care makes these studies unique. Direct observation is considered to be the gold standard for measuring quality of care as it measures actual performance. We know that medical records, obviously, sometimes are complete. Facility readiness assessments may show that the supplies are there, but they don't necessarily predict performance. So this presentation will share findings only for quality of care in labor and delivery. The survey was rolled out to 7 countries in sub-Saharan Africa from 2011 to 2012, and I'll share the findings from 6 of these countries. In the development of the tools that were used for direct observation, which were then loaded onto smartphones, we used global guidelines, including the WHO Impact Series and Helping Babies Breathe. These are evidence-based standards, and infection prevention and respectful maternity care was integrated into the tools. This is a summary of the sample, And it varied in each country according to the Ministry of Health's requests. But in completely, we looked at 643 facilities, observed over 2,500 deliveries, and interviewed over 1,000 health workers. In Kenya, this study was part of the Kenya Service Provision Assessment. And in Tanzania, it was part of a program evaluation and actually also included lower level facilities. The surveys provided a wealth of data, and I'll just share some key findings with you. So why should we observe care? This slide gives us an idea of the quality practice gap. All of these interventions indicated here should be delivered to 100% of the women. But what we can see is that the top of the green bar indicates those who did not receive the intervention for various reasons. The pink, red, and blue colors show that some women did not receive the intervention. And this is for various reasons. For example, even when the facility had supplies, such as soap and water for hand washing, only 40% of providers washed their hands. And we know yesterday we heard how important this is in preventing infection. This type of information, but then more positively, if we look at the number of women who received a Utritonic, the second column, to prevent postpartum hemorrhage, it was a good result. This type of data can be used by countries when they look at how to shape their quality improvement strategies so that they can address provider behavior. How can we make it easier for people to wash their hands? How can we make sure that hand rub is available where it's needed? This slide shows some data on how women were screened for preeclampsia or eclampsia during labor and delivery. Preeclampsia can occur in pregnancy, in labor, and after birth. And it's important that screening continues through these periods. Over 3/4 of the women across the countries had their blood pressure checked, but you will also see that fewer were asked about danger signs such as headaches, and very few had their urine tested for protein, which is one of the signs that we're looking for to identify preeclampsia. Moving on to a more detailed slide on immediate newborn care. All of the interventions here should be provided to the newborn after birth. And you can see there's a significant variation between the countries. But overall, many babies were dried with a towel immediately after birth. But fewer babies were breastfed within the first hour or were placed skin to skin on the mother's abdomen, which we know can keep the baby warm and is considered a high-impact intervention. There were some cases of actual newborn resuscitation observed, and these are reported qualitatively in the reports. So the key findings of these studies identified notable strengths across the countries. Most women received a Utritonic after birth, and most babies were dried immediately after the birth, but there were missed opportunities. For example, many babies were not breastfed or kept warm skin to skin after the delivery, and we know that this is a low-hanging fruit to save babies' lives. Many women are also not being screened for preeclampsia, and this continues to be a big problem for us as we see postpartum hemorrhage reducing and preeclampsia and eclampsia staying not much change. The other finding from the studies was the constraints that exist in practice. For example, some countries still have out-of-date guidelines about the administration of drugs in preeclampsia and eclampsia. Magnesium sulfate is the drug of choice. Sometimes it wasn't clear in the guidelines, and sometimes it wasn't available. So what? We did the studies, and then what happened? The findings of the quality of care assessments led to specific actions, and I'd like to share some examples with you. In Ethiopia, the findings were used to advocate for increased use of magnesium sulfate. In Kenya, as part of the National Service Provision Assessment, they guided the development of regional work plans. In Madagascar, they were used to advocate for national adoption of the Helping Babies Breathe program, as well as improved use of certain interventions like the partograph. In Mozambique, again, they highlighted the need to improve newborn resuscitation, and MCHIP advocated for Helping Babies Breathe to be rolled out as national policy. In Tanzania, we work closely with VSI, Venture Strategies and Innovations, to improve misoprostol supply, particularly in lower level facilities where oxytocin, which needs a cold chain, may not be available. And this stock out data was used to galvanize actions for tracking maternal health drugs. In Zimbabwe, it formed part of the National Quality of Care Assessment. And then in Rwanda, the findings were used to support development of 3 major documents in basic emergency obstetric care, post-abortion care, and Helping Babies Breathe. So looking ahead, as global efforts and countries expand quality of care activities, MCHIP's tools and resources have much potential. However, we recognize that this is a very resource-intensive process, and that we're considering now a simplified observation checklist which really captures the main components of quality of care that could be used for routine supervision. These tools have also been used in, one module has been included in the service provision assessment. It's been used in Malawi, Bangladesh, and Nepal. The World Bank have used the tools in Kyrgyzstan for an assessment of facility-based births. And as we speak, a study is being completed in Pakistan, where we also adapted the tools to capture postpartum care and the use of postpartum intrauterine devices. The tools are all available, and the studies from the countries on the MCHIP website, so please look out for these. And to finish, I'd like to acknowledge and thank the many stakeholders who were involved in these studies, led by the Ministry of Health and Country, as well as the staff and clients of the many facilities where we observed the care. There was data collection teams in each country, supported by core staff here in Washington, D.C. There was national coordinating agencies for some countries. In Kenya, Measure DHS contributed. And I'd also like to acknowledge the support of Washington here, our colleagues, Mary Ellen and Debbie and Nahed, for their ongoing support. Thank you.
Thanks very much, Sheena. I have to admit, I thought this was an incredibly important activity that MCHIP took on, and I think the results show us that they've been real leaders in this area. Our next speaker is Hilary Chiguvare. He is the MCHIP Zimbabwean Technical Director, and he's going to speak on standards-based management and recognition in Zimbabwe. Dr. Hilary Chiguvare is the Technical Director and Maternal Health Advisor for MCHIP in Zimbabwe. His current interests are in human resources for health. Before joining MCHIP in 2010, he worked in HIV prevention with ISPED. He'll have to explain to us what that is. Reproductive health and senior program management with UNFPA. He's provided technical support in health system strengthening to other countries. And 14 years ago, he started his career as a district medical officer in one of the remote districts in Zimbabwe. He has qualifications in medicine, public health, and maternal and child health. We welcome you. Hilary.
Thank you very much, Debbie, for the eulogy. I bring you greetings from 13 million Zimbabweans who have left at home. what I'm going to do in the next 8 minutes is just to take you through a journey of the efforts of the government of Zimbabwe in trying to make a difference for mothers, newborns, and children. MCHIP started working in Zimbabwe in 2010, mainly supporting the Ministry of Health and Child Welfare at the national level in terms of strengthening the development of policies and strategies, but also working in one of the provinces where deaths due to maternal newborn deaths were highest in terms of program delivery. And also just focusing in 2 districts, trying to test out how could Zimbabwe as a country build back better after some challenging years of economic difficulties and HIV and AIDS. And the areas that we were supporting were mainly in maternal health, newborn health, child health, family planning, nutrition, and immunization. When one looks at the trends in terms of the mortality deaths for Zimbabwe in the past 20 years, it really paints a sad picture. And rightfully so, the government of Zimbabwe is taking leadership in terms of trying to address that unacceptable trends in mortality. And you will notice that the maternal mortality ratio, which is the number of women who die due to pregnancy-related deaths, is more than trebled from the 1990 baseline. And the number of children that are also dying has also increased, worse so for newborns. And this situation, ladies and gentlemen, is unacceptable. Yet, this is in a context where women are coming to the facilities to book for when they are pregnant. And the government of Zimbabwe has made tremendous efforts in making sure that there are health facilities within a 10-kilometer radius. But then the question that comes to mind is, why then are the visits that the women are making not making a difference in their lives? Why are they leaving the facilities without their lives? Why are the women losing their lives? Why are children living their lives when they would have come to our facilities? So in an effort to try to strengthen some of the issues, to address some of the challenges that the ministry has been grappling with, MCHIP identified perhaps contributing to improving the quality of care for saving mothers, newborns, and children, while recognizing that other efforts, complementary efforts, needed to be channeled towards strengthening support to HIV/AIDS, which was also taking a huge toll on the lives of mothers, newborns, and children. And the idea was not just to continue to look at just numbers, but to look at what happens during these visits when the mothers, newborns, and children come to the facilities. And the tool that the project implemented is what Barbara talked about, is the standards-based management and recognition approach, which we thought was a very simple enough tool to be implemented in a simple health system like the Zimbabwe's one. And basically it has got just 4 steps. You set standards in terms of what is it that you would want to make sure that you would save lives of mothers, babies, and children. You implement those standards. Over a period of time, you measure progress. And those facilities and health workers that would have made a difference are recognized by themselves and also by the Ministry of Health and by the communities. The project was implemented initially in 2 of the districts where the toll for maternal and newborn and child mortality was the worst. And we were reaching at least almost 500,000 of people in Zimbabwe. And these facilities were responsible for over 80% of the deliveries in those 2 districts, and over 90% of the deaths were actually occurring in these particular facilities. The Ministry of Health and Child Care led from the front and actually supported the setting of standards, which is the first step in the 4-step approach that I just talked about. And they involved lots of other partners. And in total, 150 standards were put together and used by facilities to measure progress in their own health facilities to try to identify when and why women and children and babies were losing their lives. From the results of measuring their performance gaps, they identified clear reasons why women, babies, and children were dying. And efforts were made then to strengthen mainly supporting clinical-based, competence-based training, refurbishment of facilities, and in some contexts, it was just a matter of just reorganizing health services and also revitalizing supportive supervision and building the capacity of local district health executives and local health teams to be able to manage health services better, and also to transfer knowledge, skills, and competencies to their fellow colleagues. And the last step, which makes this particular tool or approach unique, was the recognition, which was also implemented, and in this case, a high-level person from the Ministry of Health and Child Care superseded it at the recognition ceremony to actually recognize facilities and health workers that had managed to exceed the set target. And some of the results, if you look at the results from the baseline, from a context where health workers would on average just do correctly 1 in 5 of the steps that are needed to save lives of mothers, newborns, and children. After implementation of those steps that I just talked about, at the end of 3 years, all the facilities, the 17 facilities that were included in the project, managed to record a marked improvement, and 80% of them, and all of them reached 80% of the standards on average. And we started to see, based on data that was coming from the routine health information system, that from the start where on average in over a 3-month period, over 200 newborns were losing their lives. After just a year of implementation, that figure was dramatically reduced to about 50%, and that number has been sustained over a period. And the government of Zimbabwe is making efforts to make sure that those gains are sustained and continued moving forward. And if you look at what happened for mothers, you would notice that the government of Zimbabwe also addressed the 2 main killers of mothers, which are bleeding at the time of birth and delivery, and also managing and also complications of pregnancy. And what you would notice is that at 2 of the facilities which traditionally used to record the highest number of deaths, we managed to, one of the facilities, the Mtambara, actually managed to record a 0 death of mothers, which was very good. And also one of the facilities, which also acts as a referral hospital, over the period of time, managed to reduce deaths due to complications of pregnancy by 6 times over the period of the implementation of the study. Having noted the improvements and in the project implementation, the government of Zimbabwe has taken a leadership in expanding this approach to child health, so that sick children would also benefit from this promising intervention. They've also expanded this to also work with community health workers. And when you look at the results from working with village health workers who are at the community level and are at the first point of call in terms of managing sick children, before the project was implemented, almost they would just do correctly about 30% of the steps that are needed. But at the end of the project, in the project site, you would notice that there was an over 3-fold increase in the performance of the village health workers compared to the sites where the intervention was not implemented. And they have not just ended there. The government of Zimbabwe has also taken a leadership role in terms of trying to make sure that this promising intervention is taken up to scale at national level. They've just completed a nationwide comprehensive quality of care study, and at the Ministry of Health and Child Care head office level, they've now set up a dedicated unit just to look at quality improvement and quality assurance work. And within that, that unit has already completed the development of a quality improvement policy and strategy, which is going to inform quality work moving forward, and also the revision of several clinical training packages and approaches, including revitalization of documentation and reporting systems. And in terms of the next steps moving forward also, other partners have also taken on board expanding this promising intervention, especially if you look at the World Bank. They've taken it to make sure that as they roll out their performance-based financing, they also take positive elements from the project, and also the expansion of this quality improvement process to cover the whole province beyond just the 2 districts. And also from the findings of the evaluation that was commissioned by the USAID, we have gone on to strengthen the streamlining, refining, and simplifying the processes and tools so that the process is easier to implement and can be taken up to scale by more facilities. And the whole process is now influencing quality work at national level. And lastly, I would like to acknowledge the support that the government of Zimbabwe has been providing, and the leadership and the stewardship, as well as the funding that we received from the USAID and communities in the project sites, as well as several communities that came to make use of the facilities where the project was being implemented, and also several partners that are supporting the Ministry of Health and Child Care in terms of trying to make a difference in the lives of mothers, newborns, and babies. Thank you.
Thanks very much, Hillary. What exciting work going on in Zimbabwe. Our next speaker is Gunjan Taneja. He is the MCHIP Indian State RMNCH Plus A team leader. He's going to speak to us on the rapid quality improvement for immunization in India. Dr. Taneja is the team leader in Jharkhand, India, with MCHIP, and he has started his professional journey in July with MCHIP in July of 2010 as a technical consultant for routine immunization in certain districts in Jharkhand. And then he became the state technical officer for routine immunization and newborn care. And he's finally moved to his current designation as the state team leader. He is a medical doctor with postgraduate training in community medicine. And since his postgraduate days, he's worked across various public health domains and has a keen interest in epidemiology and health economics. He's an avid writer and has authored 20 journal articles. That must be part of the 60 that Koki was talking about earlier, and has presented many papers at international and national conferences. We welcome you.
Thank you, Debbie, for the introduction, Barbara for introducing the topic. And while my professional journey started with MCHIP, it was the first job I took up after my post-graduation, and it's been a privilege working with MCHIP. The project has given all of us a lot. Quality is the key. It's the in thing across all aspects of healthcare, and I'm here to discuss a quality improvement model, a supportive supervision approach, which was implemented by MCHIP in India, which is referred to as the regular appraisal of program implementation in district. And I'm presenting here on behalf of the entire India immunization team. But before I move on, I'll just give an overview of how MCHIP has supported the Ministry of Health and Family Welfare. The program started in 2009, and for the first 4 years, the support was across the thematic areas of immunization, essential newborn care, postpartum family planning, and nursing, pre-service nursing and midwifery education. And it was during this period that this particular approach was introduced for immunization performance improvement in India. 2013 was a paradigm shift in India's health history. Following the National Call to Action Summit, which we heard about from the minister yesterday, the government of India launched the national RMNCH plus A strategy. And for the last 1 year, 1.5 years, MCHIP support has been primarily in implementing this strategy at the national level and in the 6 USAID focus states where USAID is the designated state lead partner. And here RAPID has been expanded to new areas for immunization and also adapted for other RMNCH services. India is the largest democracy in the world, we all know that. And similarly, India's immunization program is the largest in the world, with an annual cohort of 27 million infants and 30 million pregnant women. And at the time when MCHIP started working, the full immunization coverage was around 61%, thereby meaning that still more than 10 million infants were not fully immunized by their first birthday. So this is where MCHIP came in. The goal was to strengthen and improve the quality of the national immunization program by providing technical assistance at the national level and in the USAID focus states of Uttar Pradesh and Jharkhand. How was it done? By demonstrating and advocating for scale-up of effective immunization practices, RAPID being one of them, building capacity of health workers, managers, officials, and partners, and above all, working in partnerships, generating ownerships within the health department and the staff members, and leveraging resources from the government and partners to achieve impact at scale. So what is RAPID? It's the regular appraisal of program implementation in district, one of the new and innovative supportive supervision approaches used by MCHIP for system strengthening and capacity building with the goal of improving program performance at the district and sub-district level, impacting both the quality and the coverage. What is done in here? It's a supportive supervision round which provides a snapshot of the entire district and covers the district immunization performance over a period of 4 to 5 days. How it's done, I'll be coming to in the next slide. It guides health managers and workers to improve program performance across the thematic areas of program management, cold chain, recording and reporting, and immunization safety by on-site mentoring, on-job corrections, and providing relevant feedback at all levels. The performance is repeated, or the rounds are repeated every 3 to 6 months until the performance is improved and sustained. This slide in a nutshell provides how the entire activity is conducted, getting buy-in from the district officials to the actual implementation of the rounds and followed by successive rounds. How it's done? Before, and the foremost important point is, before the activity, a lot of preparations go into it. Planning from the topmost administrative levels to the health facilities to ensure that it's a pre-planned activity and not conducted in an ad hoc manner like most supervisions or monitoring rounds take place. The first day essentially is for the training of the supervisors. The supervisors are selected from the health staff itself, of the people and workers who work with the immunization program in that particular district where this round is being conducted. They are trained through structured checklists on all immunization-related thematic areas, and more than 2,000 health workers have been trained during these orientation workshops. The day 2 is hands-on training of the supervisors, where they are trained on-site through the structured checklist to facilitate data collection process. The 3rd and 4th day are the actual days where field visits take place to all the cold chain points in the district and a sample of session sites for data collection, on-site mentoring, and on-job training. The supervisors, I would again say, are people from the district health staff themselves and partners who are working in that particular district. The final is the day of dissemination, where results are shared, data is compiled into an Excel-based software, and action plans are drawn up. 60 rounds have been facilitated by MCHIP in 35 districts during the project period. A similar round occurs after 3 to 6 months, which is more intensive to measure the progress in the interim period. But these rounds are not a one-off phenomenon. Visits take place in between the two rounds to the health facilities to ensure that the action plans are well implemented. So what's the impact? We see how the quality has improved, vaccine storage practices before and after intervention. Similarly, injection safety practices before and after interventions. Results are presented across in various ways. This is a snapshot from the thematic area of records and immunization safety, where improvement is noticed from the first round represented by the blue bar going up to the last round represented by the red bar. And these are from some cold chain points in the state of Jharkhand. The facilities are scored through the Excel-based software, which mark their progress from poor performing to good performing. The important point is not only achieving the good category, but sustaining it. So there are instances when facilities fall off, which these scores help to flag off for immediate action. So overall, this is another way of representing the results, and we can see how in the MCHIP focus districts in India, the facilities have graduated in Uttar Pradesh from being 84% poor in round 1 to more than half of them going to the good category after round 4. And similar results are demonstrable for the state of Jharkhand also. We have been successful in linking RAPID to another of our interventions, the demonstration sites, which serve as centers of excellence or for cross-learning sites for peer learning, and 8 such demonstration centers have been established by MCHIP in its focus districts. Some of the snapshots of how a demonstration site looks like, just touching upon one aspect, and a snapshot from a cross-learning exercise. And the important point here to note is that the facilitators in the cross-learning sites are the health staff themselves. A sense of ownership and capacity building has been generated through MCHIP support, and it's the members working in the facilities are those who have taken up the lead role now, with MCHIP just being at the back. Does it impact coverage? This is Uttar Pradesh, the largest state in India, the 6th largest state in the if it had been a country, it would have been the 6th largest in the world. We see that there is progressive improvement as far as coverage is concerned, but more marked in those districts where the immunization program has been supplemented by regular rapid rounds. Can it be scaled up? We have results to show that there has been an improvement in quality. Well, definitely it has been scaled up. We started from just 5 districts in the country where MCHIP was implemented these rounds, and now we have gone up to 84. That's a big number as far as even if India is taken into account. Seeing the results, the state of Jharkhand and Haryana in India adapted the process, and they are implementing it through their own resources by budgeting it in their annual health plans. Partners have taken it up. Uttar Pradesh has scaled it up in 32 of the 75, UNICEF has scaled it up in Uttar Pradesh in 32 of the 75 districts, and now it's also been implemented in some of the African countries. This has been possible because we have identified a few critical indicators. We have kept the checklist simple, but with repeated rounds, we have gone down more intricately into the quality aspects by morphing to new checklists. Government ownership has been the main aspect on which we have worked upon. Staff ownership, accountability of the people working at the facilities, and mobilizing financial and partner support have been other factors which have led to the scale-up. So, in conclusion, I would state that RAPID is an effective tool for measuring the quality of immunization services. We have results to demonstrate it. It's replicable, sustainable, scalable, because it generates community, not only community ownership on the part of the health workers, accountability on the part of the health workers through joint problem solving and situation analysis. It inculcates a sense of behavior change through the on-site mentoring visits which take place. And in the current context, in not only India, but across the globe, easily adaptable to other RMNCH plus A services, as it has been adapted by the MCHIP team for newborn care in India and by the state of Haryana for measuring the overall performance improvement in the district and not just restricting to routine immunization. I would end by acknowledging the wholehearted and unconditional support which has been provided by the Ministry of Health and Family Welfare at the national level, all the state governments, Jharkhand, Uttar Pradesh, Haryana, Uttarakhand, Madhya Pradesh, Odisha, the USAID India mission, the mission here at the headquarters, the MCHIP India team, the MCHIP immunization team at the headquarters, development partners, WHO, UNICEF, CARE, BMJF, who have supported MCHIP unconditionally, and above all, health officials and frontline workers who implement India's universal immunization program. So thank you.
Thank you very much. A very exciting program. As I said, we've got some great work going on here at MCHIP. Our last speaker is Veronica Reis. She is the MCHIP Chipaigo Senior Technical Advisor for Respectful Maternity Care in Mozambique. Veronica is she's an OBGYN, and she's based in Brazil and provides technical support for countries in Africa, including Mozambique, Latin America, and Asia. She has worked for Chipaigo for 18 years and has worked in Mozambique for 4 years, where she served as the technical director for Chipaigo and the MCHIP programs there. I will also add, I know Veronica is an incredible advocate for this work, and I think she's influenced a lot of people with her work on the model maternities and respectful maternity care. We welcome you.
Thank you, Debbie. Good morning, bon dia to everyone. I'm here in behalf of the Mozambique team to present the efforts that have been done in Mozambique to promote respect for maternity care. So Mozambique is an African country with 24 million people, and the maternal mortality around 408, and neonatal mortality around 30 per 1,000 living births. And the coverage of skilled birth attendants is around 54%. Respect for maternity care has been increasingly recognized as a dimension of quality of care. And this approach is centered on the individual and emphasizes the right of mothers, newborn, and their family, and try to consider the woman's preference and need. Respect for maternity care is linked to other movements, such as the humanization of childbirth that is increasing in Latin America, and also the movement to prevent disrespect and abuse during the maternity care. Mozambique has been doing a great effort to promote respect for maternity care. They call humanization of care in Mozambique, and they have been doing this under this model maternity initiative that is one strategy adopted by the Ministry of Health of Mozambique with support of USAID and MCHIP. This initiative started in 2009 in the biggest 34 maternity in all provinces of the countries. At that time, it covered around 18% of the deliveries in the country. And this initiative has been scaled up year by year. And in 2014, they have 124 facilities involved in this initiative, and it covers around 36% of the deliveries in countries. What Mozambique has been doing is that Mozambique has linked this effort to promote respect for maternity care with the effort to improve quality of care using the SBMR approach. And Mozambique introduces standards related to respect for maternity care in the list of quality standards in different areas of maternal and neonatal health care. So these standards try to reflect some respect for maternity care practice that has been promoted in Mozambique, such as respect for beliefs, tradition, and culture, the right for information and privacy, the right to have liberty of movement during labor, the right to choose and have accompanied during labor and delivery, the right to choose the position for childbirth, and keeping mother and baby together. All of these practices is evidence-based practice recommended by the WHO that can benefit the process of labor and delivery, and they also can contribute to prevent some complications. The Modern Maternity Initiative include interventions such as training, strengthening national policy and guidelines, provide technical assistance, strengthen health information system, and try to mobilize and involve the community. Also, Mozambique has been investing in improving infrastructure and privacy. This is one of the biggest hospitals in Mozambique, José Macamo Hospital, and they have improved a lot the infrastructure in those hospitals. So Mozambique has been tracking the achievement of standards, and here we have the result of 88 facilities in Mozambique from 2009 and 2013. And we can see that they had improvement in all of these areas, in all of these facilities. And also Mozambique has been tracked some health indicators. Some relate to clinical practice, but the other relate to respectful care, such as early breastfeed, skin-to-skin contact, labor and with company, and delivery in vertical or semi-vertical position. And this is the result for 102 facilities from 2009 and 2013, and we can see an improvement in all of these standards. Here is to show the difference between one facility from the urban area and the rural area, and to show that the permission to have a company increased faster and more in the rural area than in the urban area. And Mozambique has also been tracked some high-impact intervention practices, such as the use of partograph, the management of third stage of labor, and the use of magnesium sulfate to treat eclampsia and severe preeclampsia. And this is the result of 102 model maternities in Mozambique from 2009 and 2013. And all of these indicators have been improving during this period. And also the maternal mortality has been decreasing in all of these facilities. Mozambique has also been tracking the client satisfaction. They use like box to people to put the evaluation of the care. And they also conduct some exit interview. And they can show that the satisfaction of client has been increased. And here we have some quotes. The first one is from one mother that was allowed to accompany her daughter during the delivery, and she said, "This is what I can call true independence." And this other couple, the lady had her first baby accompanied by her husband and in a squat position, and she became a champion to support this movement, and she said, "We women must speak up to fight for our rights." And her husband, he said, "It was the most incredible experience of my life." So it's so nice to see the reaction of the population. So this is the way to improve quality and the respectful care. There are a lot of challenges in this process, but we have learned some lessons learned, and we can have some recommendations. We learned about the importance of advocacy, the political commitment, and I can say that we have this commitment in Mozambique. We have here the Minister of Mozambique, Dr. Alexandre Manguel, that has personally supported this process.
That's great.
Thank you, Doctor. And also the importance of incorporating the gender and the right perspective in our program to identify champions and opportunities to partnership and to have a budgetary commitment to support this kind of intervention. It's important to also recognize and support the committed team. And it's important to go to the consolidation. And to the consolidation, we have learned that it's important to scale up but also to focus in small number of facilities to ensure that they will achieve the desired level of performance to be recognized. And also it's very important, the monitoring and evaluation. So we are glad that in a recent analysis conducted by MCHIP in 13 countries revealed Mozambique as a global leader in monitoring quality of care, including evidence-based respect for maternity care practices. And also we have some facilities that have achieved this level of performance to be recognized as a model maternity. In the last June 16, the hospital of Xai-Xai was recognized in a public ceremony. And Mozambique has 2 other facilities that will be recognized next month. So we are glad to see that the maternity has been really improved the performance. Looking to the future, Mozambique plan to continue work to expand and consolidate this process to better define, improve, and measure the implementation of respect for maternity care, make clinic and staff more welcome of women, men, and couples, and give special attention to equity and the needs of young people. I'd like to end this presentation saying that all women deserve, and we all have a role in assuring that all women and babies have respect for maternity care. You can find more information in this Respect for Maternity Care toolkit, and also you can contact people from Mozambique. And by the end, I'd like to thank to the Minister of Health of Mozambique, the USAID Mozambique mission. We have here Dr. Lilia Jamisi, that is a champion in this area also. And also the team from the headquarters of MCHIP and the team from USAID DC. We have champions here also. And the other important stakeholders that have been supporting this process. I would like to ask for the all team that came from Mozambique to stand up. And we would like to recognize, including the Minister of Health. Yes, please. And thank you very much.
Sorry. Wow, I told you she was a passionate advocate. But I also think what's important to see, and I think it's one of the key things we need to know, is country ownership is key. And having really high-level support and passion behind the work makes all the difference in the world. And I think both for the ministry, but I also want to thank the USAID mission. I didn't realize Lillian was here, so I'm going to have to find her. She's looking away, but I'll catch her later. So, quality, incredibly important. And I think there's a global recognition of the importance of quality. In fact, it's kind of a buzzword. Everybody's talking quality now. But I just spent 2 days in WHO in a meeting on quality of services. And even after 2 days, we couldn't define it. And we kept explicitly saying we need a definition, and we couldn't. So there's a lot of work to be done in this area. I think one of the USAID quality improvement projects, one of their leaders said as well, you know, quality, says I almost want to get rid of the word quality because some of what we need to do is talk about improvement in the processes of improvement. And I think what we have to see is that MCHIP, in the kinds of work they're doing, is trying to address some of these issues. And again, it's, as we've just been seeing, it's about ownership of this process we're talking about. Without ownership by the providers, by the ministries, it's not going to happen. So we have a piece, and MCHIP has a piece. And we need to recognize MCHIP has shown real leadership in developing tools, methodologies, to help define and describe quality in countries with a specific purpose to provide data to assist countries to improve services. And I think Sheena was really pointing that out, and she was showing how countries have used this data. We're after results. How do we improve and improve the health of mothers, children, and babies, but also save lives? That's our bottom line. And so I think MCHIP is really moving us in the right direction. So MCHIP has also been working with the global community on the daunting task of indicators. Now, Jeff Smith, our maternal health lead, has been struggling we're really struggling trying to find some indicators that we actually, on a routine basis, can measure to tell us more about quality. And the work continues into the next project, I have no doubt. Measurement is so key. Barbara talked about that. If we can't measure and show these results, how are we going to be able to say we're getting where we're trying to go? That we know that we're actually saving these lives and that we're improving services. So with that, all of that said, I do want to thank this amazing panel. They've been provided an important picture of the type of work that MCHIP has been doing around quality. And we know that it doesn't capture all. Barbara pointed that out, and I know that even in Ethiopia, we're doing something called the rapid audit and feedback, trying to increase the use of mag sulfate. They're using methodologies that other groups have pioneered, and I think this is all great. Whatever works and it's important to try and figure out what works in these settings. So I want to end with some key points that I think we need to keep in mind as we move forward. Ownership of the process and the need to improve quality needs to belong to the providers and to the ministries of health as we move forward. We're just assisting in that process. And it means they need to also help in the development of it. And I think we're seeing this. The rapid process where they're including the providers as they're, in their supportive supervision as they move forward showed us this. And I think as well, our Zimbabwean Hillary was talking about that as the SBMR process gets developed. So I think that's great. And we need to ensure institutionalization and sustainability. And I don't think we can find a better example than in Mozambique. And I have been there to see the model maternities, but to watch the increase in numbers, from the small numbers up to 134, 36%, fabulous to see. Measurement. I think even yesterday, we're hearing more and more about the importance of results. We need to do that. And we need to make sure that our quality is more than just safety and clinically sound standards, but that in fact, patients and patient satisfaction have to be a key part, and clearly Mozambique's work is showing us how to do that. So, quality is a key component of our real move towards results, and we need to give MCHIP a big round of applause for the work they've done in this area and the work they'll do going forward. Now, I'm told there are two microphones over here, and we have a few minutes now for questions, and I'm sure there are some great questions out there. If you could go to the microphones, we'll take questions to our panelists. Oh, good. People are jumping right up. Okay. Take it away. Please introduce yourself, and then
Thank you very much. I'm Charles Monsombo. I'm the Chief of Health Services from Malawi. I need to commend all the MCHIP teams for the excellent work you've been doing in the various countries. I think I'll leave myself to just one question since there are many of us around here.
Thank you.
And it will go to Dr. Taneja, India, on RAPID, this regular appraisal of program implementation in districts. I know that as we're introducing more and more vaccines, the cost of the vaccination is going up. And of course, I'm not an economist, but people talk about economic analysis and cost effectiveness. And we're also talking integration in the supervision. So how, in your summary, you say this is replicable, sustainable, and scalable. So I just want to find out if we did an economic evaluation of cost effectiveness of the intervention, considering that we need to save the resources for the new vaccines. Thank you.
Thank you. Very good question. Do we have any more before we turn it over to our panelists? Yes, please. Hi, Lillian. Come to the mic. Oh, and there's, okay, sorry. My good friend Indira. Yeah. Yes, please, Indira.
Thank you, Debbie. And thank you for wonderful presentations. It was really great to hear. What would be your suggestions, as long as we have NGOs or groups that are sort of facilitating the processes, the results always seem to come out in a nice way that we can present. What would be your suggestions to ensure sustainability after the group either moves on to another country or to another place? Because we find in some of these places, to get the supportive supervision of the supervisors going to a place to ensure that these things are moving well, And sometimes we get the health workers to come to a common place. We've tried different methods. So what would be your suggestions to ensure that this quality improvement can continue?
Thank you. Very good question. And we'll take one more before they answer. Yes?
Bom dia. Vou falar em português.
Ooh, okay. I hope somebody will translate for us.
Yes, I will do my best to translate.
Thank you, Kim.
A pergunta que vou fazer é para a Índia. Gostaria de ter a seguinte experiência. A maternidade é um processo de risco, desde o processo da gestação, que inicia na consulta pré-natal, até 42 dias após o parto. Então, gostaria de saber da Índia, quando fazem a análise das 5 maternidades que iniciaram, até 42, até 84 em que estão atualmente, como é que avaliam este processo em termos de resultado? Porque temos, para avaliarmos que a maternidade está bem,
Thank you, though.
Mas este foi para a imunização.
Sim, sim, sim.
Talvez pode trazer um pouquinho.
I'll try to translate. Good morning. My question is for India, as she said. India started in 5 provinces, in 5 districts, and 284 districts. And as you know, the maternity is the pregnancy is a risk situation, since from pregnancy to a postpartum period. How do you control? Which results do you use to see that you are achieving actually the results expected in your intervention? We observed that India presented about immunization, and she is asking about other areas that were presented also during the presentation, related with maternal mortality.
No.
Is it clear?
Is it clear?
Sort of, yes.
Okay, they say yes.
Yes.
Well done.
Okay, so with that, we will turn it over. I know, Dr. Taneja, you have a couple of questions, and then the other one's open to everyone. Do you want to start?
Okay. Thank you for the questions.
I don't know if they...
I think
You're okay, I think.
It's on. Yes. Well, the first one focused on the cost effectiveness of the process. New vaccines are being introduced. They themselves are costly. So if we are increasing the cost of the immunization program by introducing new vaccines, we definitely need to look at the quality of the new vaccines. And for looking at the quality, we need a process which is sound, which very easily measures the potency of the vaccine, which looks at the immunization program in a snapshot, not only looking at the vaccine storage practices, but vaccines as such are dependent on a number of other aspects. The human resources who deal with the vaccines, their recording and reporting processes. So if we move into the qualitative aspect of the immunization program, or as such for any program, as if we start with a coverage of 10%, then our main aim is to improve the coverage, to increase the access to the people so that services reach people. And it's not that at that time that quality becomes of paramount importance. It is important, but then access at some places overrides it. But when we start going from 50 to 60 to 70 to 80, it's at that point that quality comes in. With new vaccines, it becomes all the more important. And in India demonstrates us the fact that routine immunization coverages have stagnated after reaching 70%, 80%. Even some of the good performing states are now seeing a decline in coverage. So possibly the thing missing in the missing link is quality. And of course, there is a budgetary aspect, but then I think the governments, when they take it over, as has been done in India, us being technical partners, we somehow override upon that barrier. When the government has adopted the approach, they devise ways to fund it. And with new vaccines, I would again reiterate the same fact that with new vaccines coming in, we definitely need to have more we definitely need to give more importance in quality. And if we can spend $100,000 on introducing and rolling out a new vaccine, we definitely can budget a small amount of money to ensure that they are being implemented with high quality. For the next question on how it has been expanded to other areas, that I believe is the question, we have results which show that this approach has been very well implemented for newborn care. The same approach, having a sweep of all the newborn care facilities in a district to assess newborn care services. Newborn care being a more technical sort of area, providing on-site mentoring to the healthcare providers. We have the Rashtriya Sishu Suraksha Karyakram, which is essentially the essential newborn care and resuscitation component. So that includes a lot of on-site mentoring, and this approach has been adopted for that, has been successful for that. And in the state of Haryana, as I said, the mission director or the administrative head of the health services in Haryana has adapted this approach to review the entire district performance. His team goes out into the district, works with the district people, and then with a day-long meeting, they review all the important components. Sometimes the meetings start at 9 in the morning, go up to 12 in the midnight. So this is an approach which we have developed for immunization, and it has been successful for that, and definitely now we are seeing that it's being adapted to other areas. And if
okay.
So
go ahead. No, I just for the other question. Any more on that question?
No.
Okay, great. So maybe we will turn it to, you may have something to add later, but to the other folks on that particular question. Veronica, you look like you might have something to add.
Yes, about sustainability and institutionalization. I think that some things is very important to ensure the sustainability. I think the first thing is the local ownership. Like in Mozambique, it's really the Ministry of Health that is the leader in this process, and the partners has been supporting the Ministry of Health. Also to use the existing mechanism in the system, like the mechanism for supervision, the health information system, because when the project ends, this mechanism will continue. So increase the capacity of the Ministry of Health in this area is critical. And the last thing that I think is important is involve all the partners. Like in Mozambique, we have been working with the WHO, UNICEF, UNFPA, all the partners that have been working with the USAID fund. And they also involve like a medical school, training institute, civil society. So I think as much people as we have involved in this process can ensure the continuity of this process and the sustainability. Thank you.
I just want to see if Hillary has anything to offer, because I know they're doing the same in Zimbabwe.
I just wanted to add that for purpose of sustainability, I think programs or projects, you have to recognize that whatever interventions they want to implement, they are implementing it in a health system. And they should look at a health system as a living being. It has got a life. And as such, you have to make sure that you have to address who owns that particular health system, and make sure that you bring on board from the onset the local leadership, also the ministries of health, and also the issues of scale. It doesn't make sense to go to a minister of health and propose to implement an intervention just in a small corner, just addressing one of the several of the myriad of problems that they are facing. I think you also need to look at the whole continuum of looking at health from a holistic approach and making sure that you are taking your interventions to a scale that really justifies the involvement of high-level ministries of health. And the last thing is, I think, continuous engagement. That there are clear timelines in terms of when you are starting, for how long we are going to be supporting the Ministry of Health and holding each other, and also to agree on clear terms of reference in terms of the transition plans. When you leave, who is going to take over, and whoever is going to take over, what sort of capacity do they need
telling me
to,
forget it.
to have in order to
let you
move
do
the
it.
process
Tell her
forward.
no.
I think those are the key issues
I know.
that are important for
agree.
sustainability.
I am overriding my bosses and letting the last person over here, Lillian Jimmy's, have her question, because they're telling me we got to be quick, though, or they're going to drag me off the stage. Yes.
Thank you very much. I don't have a question, but I have a comment. My overall comment is I am challenging our team, our great MCHIP team, to move from process indicators and bring us result indicators. We want to see how this intervention impacts in maternal mortality, neonatal mortality. We want to see how this impacts in reducing stillbirth, how this impacts in reducing deaths from postpartum hemorrhage, how this impacts in reducing deaths from eclampsia. So please let us, it's a challenge for us, for all of us, to move from those process indicators, the SBMR indicators, to result indicators, impact indicators. Thank you.
That's a great ending, because I think that's really where we all need to go. Thank you,
And we'll leave
Lillian.
it there.
And with that, a big round of applause for our panel. There we go.
Thank you.
And we'll be back for the community session in 20 minutes.